Assalamu alaikum. Hello everyone. Hello great surgeons. Today we are going to start our head and neck anatomy lecture. This is first lecture for head and neck anatomy. I will try to share first slide for today. This is by discussing triangles of the neck. I will try to zoom on this picture. As you see here, we have anterior triangle and posterior triangle. A major muscle found within the lateral aspect of the neck, it is the sternocleidomastoid muscle here, this one. This muscle has origin from below, from manubrium sterni and medial 1/3 of the clavicle, to be inserted here into the mastoid process and lateral 1/3 of the superior nuchal line. This is the sternocleidomastoid, which is supplied by spinal accessory. And its function is to turn the head and the face to the opposite side. This is the function of the sternocleidomastoid. This muscle is responsible for dividing the neck into anterior triangle, as you see here, and posterior triangle. Let's start by the anterior triangle. Anterior triangle boundaries, this is the anterior border, which is the midline. This is anterior border of the neck. This is the midline. Posterior is the anterior border of the sternocleidomastoid. Above, you have the lower border of the mandible. This is anterior triangle. You have, as a content of this anterior triangle, 1.5 muscle. 1.5. This 1.5 muscles are dividing this anterior triangle into 3.5 triangles. So 1.5 muscle are responsible for dividing the anterior triangle into 3.5 triangles. First muscle is called digastric muscle. Digastric muscle means that this muscle is digastric, so it has two pillars. What are these two pillars of this digastric muscle? First one is from digastric notch of the mandible to be inserted into the hyoid bone. This is the anterior pillar. Posterior pillar is arising from the mastoid to be inserted into the hyoid bone. So this is the digastric muscle, anterior pillar and posterior pillar. This is the first one. The half muscle is this. This is part of muscle which is superior, and its inferior part is found within the posterior triangle. This muscle is called omohyoid. Omohyoid. This is superior pillar omohyoid, and this is the inferior pillar omohyoid. So please keep these two muscles. You have digastric muscle, you have superior pillar omohyoid, you have inferior pillar omohyoid, which is found in the posterior triangle. By dividing this 1.5 muscle, so here I have 3 triangles. This one, and this one, and this one. But here you have this hyoid bone, and midline, and this anterior pillar digastric. It will also make half triangle. What names of this triangle? What are the names? This is the first one, as you see here. This is called digastric triangle or submandibular triangle. Its boundaries, this is the lower border of the mandible, anterior pillar and posterior pillar digastric. Here, this one is called the carotid triangle. What is this carotid triangle? Here you have posterior pillar digastric, superior pillar omohyoid, anterior pillar sternocleidomastoid. So here, this carotid triangle is found between 3 muscles. This carotid triangle is found between 3 muscles. Anterosuperior is posterior pillar digastric, anteroinferior is superior pillar omohyoid, and the posterior is the sternocleidomastoid. Then you have here called the muscular triangle. What is this muscular triangle? You have anterior is the midline or medial raphe of the neck. Posterior superior is superior pillar omohyoid, and posterior inferior, this is the sternocleidomastoid. Here, this is called muscular triangle. These are the 3 triangles, 3 main triangles, sub-triangles of the anterior triangle of the neck. Digastric or submandibular triangle, carotid triangle, muscular triangle. Then you have this half triangle. This half triangle is formed of the hyoid bone, anterior peridigastric, and the midline. This is half of triangle called submental triangle. So again, I have here 1.5 muscle to divide the anterior triangle into 3.5 triangles. Now we have known their boundaries. Then let's go for contents of each one. This triangle is called digastric triangle or submandibular triangle. From its name, you will have here the submandibular gland and the submandibular lymph nodes. So this is called digastric triangle or submandibular triangle. I have the submandibular gland and submandibular lymph nodes. Please keep this relation to the submandibular gland. Submandibular gland is related to 3 nerves, 1 artery, 1 vein. Keep this. What are these 3 nerves which are commonly to be injured in submandibular adenectomy? Marginal mandibular, lingual, hypoglossal. Marginal mandibular, lingual, hypoglossal. The artery is facial artery. The vein is facial vein. So submandibular gland is related to these 3 nerves and facial vessels, facial artery and vein, which are arising from the external carotid. Facial artery is a branch from the external carotid artery. So they are contents of the submandibular triangle. So here you can keep what are the contents of digastric triangle or submandibular triangle. You have submandibular gland and lymph node and its related vasculature, neurovasculature. 3 nerves, marginal mandibular, lingual, and hypoglossal. Then you have facial artery and facial vein. These are contents of digastric triangle. Then let's go for this most important triangle. This is called carotid triangle. What are the contents of the carotid triangle? Its content is the carotid sheath. This is the carotid sheath. In its anterior wall, you have anterior by A. So I have ansa cervicalis. A. Anterior in the carotid sheath, this is ansa cervicalis. Posterior, you have the sympathetic chain. So anterior in the sheath, ansa cervicalis, posterior is the sympathetic chain. And the contents of the carotid sheath. What are the contents of the carotid sheath? Below, you have common carotid, internal jugular, and the last 4 cranial nerves. Above, this common carotid is divided into external carotid and the internal carotid. Also, you will have internal jugular, and above, you will have vagus. So what are the contents of this carotid triangle? They are carotid sheath, anterior, ansa cervicalis, posterior is sympathetic chain. What are the contents of this carotid sheath? It is common carotid artery, internal jugular vein, and the last 4 cranial nerves. This is the third triangle here. It is called muscular triangle. What are the boundaries of this triangle? Midline, superior piloomohyoid. This is anterior border of the sternocleidomastoid. Why this triangle is called muscular triangle? Because it mainly contains muscles. What are these muscles? They are called strap muscles. They are called strap muscles. By the way, strap muscles, they are all infrahyoid muscles. All infrahyoid muscles, and they are 4. They are sternohyoid. Then you have sternothyroid. Then you have thyrohyoid. Then you have omohyoid. So omohyoid, which is the superior belly and the inferior belly, this is a part of from the strap muscles. Here I have contents of this triangle. They are strap muscles. What else? You have anterior jugular vein. This is found also subplatysmal on both sides of the midline. Subplatysmal in both sides of the midline related to the strap muscles on both sides. Then also a very important structure. It is the loop of the thyroid gland. Loop of the thyroid gland. Both loops are found within both muscular triangles. So here, what are the contents of the muscular triangle? They are strap muscles, then loops of the thyroid gland and anterior jugular vein. This submental triangle is containing the submental lymph nodes. Then here, let's go for reading. Anterior triangle, anterior border of the sternocleidomastoid. Then you have lower border of the mandible, then you have the midline. Subtriangles, there are three. Muscular triangle, which is containing the strap muscle. Carotid triangle, which is containing carotid sheath and its content, and anterior ansa cervicalis, posterior is the sympathetic chain. Then you have this submandibular triangle or carotid, or excuse me, digastric triangle containing submandibular gland. Not only submandibular gland. Here you will go for submandibular gland and lymph node, facial artery and vein, not only hypoglossal, this is also marginal mandibular and lingual. Muscular triangle is containing loops of the thyroid gland, strap muscle, anterior jugular vein. Then you have this is the carotid triangle containing carotid sheath, which is containing common carotid, internal jugular, and the last four cranial nerves. Then also you will have ansa cervicalis in its anterior wall, sympathetic chain in the posterior wall. You have a very important muscle called digastric muscle, which is forming a boundary in each one of the subtriangles. Anterior belly is found between this triangle and this one. Posterior belly is found between this triangle and this one. So digastric muscle is an extremely important to know all its origin, insertion, and nerve supply action. What is the origin? I said anterior belly from digastric notch to be inserted into mylohyoid. Posterior belly from the mastoid process to be inserted into the mylohyoid. What is the nerve supply of this gland, of this muscle? You have, from its embryology, first branchial arch and second branchial arch. Anterior belly is from first branchial arch. Posterior belly is from second branchial arch. Anterior belly is supplied by a branch from the mandibular division trigeminal nerve. We have a cranial nerve number 5. It is called trigeminal nerve. We will know all story of this trigeminal nerve. This is divided into 3 major nerves. They are ophthalmic, then maxillary, then mandibular. Ophthalmic, maxillary, mandibular. Branch from this mandibular, because mandibular is the only motor, because ophthalmic and maxillary are both sensory. So mandibular, which is the only motor from the trigeminal, this is giving a nerve called nerve 2 mylohyoid muscle. This nerve also is supplying anterior belly digastric. Because as you see here, you will have here floor of mouth. You will have here the mylohyoid muscle, which is directly related to this anterior belly digastric. So nerve to mylohyoid will supply also this anterior belly digastric. This is a branch from mandibular division of the trigeminal nerve. Posterior is from second branchial arch, and the nerve of second branchial arch is called facial nerve. It's called facial nerve. This is all you should know about this anterior triangle. Then let's go for posterior triangles. This posterior triangle, its boundaries, anterior boundary is the sternocleidomastoid, posterior you have a which has the same innervation of this sternocleidomastoid. This muscle is called trapezius muscle. This muscle is called trapezius muscle. You should know that this trapezius muscle is originating from superior nuchal line, then ligamentum nuchae, then all cervical and thoracic vertebrae. And you remember in the upper limb that origin of deltoid embraces the insertion of the trapezius. I said before, origin of deltoid, lateral clavicle, acromion, then lateral spine. While insertion of this trapezius is impressed by the origin of the deltoid. So here from the inner surface of lateral 1/3 of the clavicle, inner surface of acromion, and superior surface of the spine. So here, origin of deltoid is related to the insertion of the trapezius. This muscle, by the way, is responsible for a very important action, which is called shrugging shoulder. What's meant by shrugging? Shrugging is elevation your shoulder. Elevation your shoulder above here. This supplied by accessory nerve, which is cranial nerve number 11. Also, this is the same innervation of the sternocleidomastoid. So boundaries of the posterior triangle, here is the sternocleidomastoid, this is the trapezius, and this is the middle 1/3 of the clavicle. Middle 1/3 of the clavicle. This is the boundaries. Then you have the floor. Floor of this triangle is sometimes difficult. Three muscles, they are forming SLS. From above below, splenius capitis, levator scapulae, and the scalenus medius. This scalene muscle is very important and has an important anatomical landmark. This is called the scalenus medius. So medius here means that you have scalenus anterior, scalenus medius, and scalenus posterior. So scalenus medius is part forming the floor of the posterior triangle. So the content is the scalenus anterior. It came in exam before. Which scalene is the content of the posterior triangle and which is part of the floor? Part of the floor is the scalenus medius, while scalene anterior is a part of the content. So here, what are the floor muscles forming the floor of the posterior triangle? SLS. Splenius capitis, levator scapulae, and scalenus medius. What are the contents of this triangle? What are the contents? We know two muscles. First one is the scalenus anterior, I said now, and this is the second one. This one is the inferior pili omohyoid. So here I have known the muscles. This triangle is subdivision, and this is another triangle. So inferior pili omohyoid is dividing the posterior triangle into suprascapular and occipital triangle. Excuse me, supraclavicular and occipital triangle. Here I have also two groups of lymph nodes. They are called supraclavicular and occipital lymph nodes. So here I have two muscles, two groups of lymph nodes, two muscles, scalenus anterior and inferior pili omohyoid, two groups of lymph nodes. They are supraclavicular and occipital. I have here vessels. I have a very important vessel which is passing from here, from the sternoclavicular junction, then it passes superficial here. This vein is called external jugular vein. So also it part from the triangle. You have here a structure found between scalenus anterior and the scalenus medius. Two important structures, and they are of very important surgical importance. Scalenus anterior and scalenus medius. Two structures are passing in between them. This is the subclavian artery, and they are lower trunk of the brachial plexus. Both structures are responsible for syndrome called tight scalene syndrome, or what's called thoracic outlet syndrome. These are responsible for this tight scalene triangle. Obstructions or compression of this triangle causes compression over the subclavian artery or to the lower trunk of the brachial plexus. So this patient may present by manifestation arterial or manifestation neurovascular. So here, this is the structure which is found posterior to the scalenus anterior and anterior to scalenus medius. What are the structures posterior to scalenus anterior? I have subclavian artery and the lower trunk of the brachial plexus. I have two important structures anterior to scalenus anterior. Two important structures anterior to scalenus anterior. What are these structures? First one is subclavian vein. Second one is phrenic nerve. So please keep this arrangement as your name, from front to the back. What are the structures from the front to the back? First one is subclavian vein. Then you have phrenic nerve. Then you have scalenus anterior. Then you have subclavian artery. Then you have lower trunks of the brachial plexus. Then you have scalenus medius. This is arrangement of the structure and very important. Relation of phrenic nerve to scalenus anterior is commonly asked each exam. Again, let's go for contents of the posterior triangle from the start. I will repeat. First one is scalenus anterior. Second muscle is inferior piloomohyoid. I have finished muscles. Then two groups of lymph nodes, they are supraclavicular and occipital. I have finished lymph nodes. Then I will go for nerves and vessels. Vessels, I said, I have external jugular, I have subclavian artery. Why subclavian artery? Because I said the floor is the scalenus medius and the content is the scalenus anterior. So posterior to the scalenus anterior is subclavian artery, while anterior to the scalenus anterior is subclavian vein. Then I have also structures related to this subclavian artery. They are lower trunk of the brachial plexus. I have a structure related to this subclavian vein. This is the phrenic nerve. Two important structures added to it. This is nerve passing between trapezius and sternocleidomastoid, which is supplying both muscles. It is called spinal accessory nerve, cranial nerve number 11. You have here branches from cervical plexus. Four important branches from the cervical plexus. And they are the last contents of this posterior triangle. First one is called supraclavicular. Second one is called transverse cervical. Last one is called great auricular, and you have lesser occipital. These are the four nerves which are branches from the cervical plexus. Again, from its sides. This is the supraclavicular. This is transverse cervical. This is great auricular, and this is lesser occipital. These are boundaries, content, and floor of the posterior triangle. Let's go for next slide regarding ansa cervicalis. We know ansa cervicalis, which is found within the anterior wall of the carotid sheath, while in the posterior wall it is sympathetic chain. Ansa cervicalis is supplying the strap muscle, which are a content from muscular triangle. What are the strap muscles? They are four muscles. Four muscles. They are infrahyoid muscles. Sternohyoid, which is from the sternum to the hyoid bone. Then the sternothyroid, from the sternum to the thyroid bone. So I have between hyoid and the thyroid, it is called thyrohyoid muscle. Then I have omohyoid, which has two bellies, superior belly and inferior belly omohyoid. All are supplied by ansa cervicalis, except thyrohyoid directly from C1 plus a branch from the hypoglossal nerve. So thyrohyoid is directly from C1 and contribution from branch from the hypoglossal nerve. Please remember, these are the strap muscles, and its innervation is coming from below upward. Its innervation to this strap muscle is coming from below upward. So please, when you are going to divide this strap muscle, you will go to divide it from below or above. You will try to divide it in its upper half. Why? To leave all of this is innervated. If you divide here, so all of this part became paralyzed. What is the function of this strap muscle? They are called infrahyoid muscles. So they are responsible for moving the hyoid below, and the suprahyoid muscles are responsible for moving the hyoid upward. Moving of the hyoid upward and below is a movement during deglutition or swallowing, and also during speaking. You may move this hyoid above and below. Then let's discuss the most common content of the carotid triangle. It is the common carotid artery. And by the way, here, this is the external carotid. This is the external carotid. I will try to show you the common carotid in the next page. As you see here in this one, this is the common carotid artery. Common carotid artery is found within the carotid triangle. Here, this is the common carotid. This is the internal carotid, and this is the external carotid. Internal carotid is a content of the carotid sheath. Related to it, internal jugular plus last 4 cranial nerves. Please tell me when and where it starts and when and where it ends. It starts, this common carotid, from the right side or left side. On its right side, it arises in the chest from artery called the brachiocephalic artery. So please focus. You have common carotid artery on the right side, which is arising from brachiocephalic artery. While on the left side, it arises from arch of aorta. This is the first one. Its course. It has a course in the thorax and has a course in the neck. As you see in this picture, this is its course in the neck. But before, it has course in the thorax. Why? The most important is left, which is arising from the arch of aorta. Here, it is crossed by a very important vein. It's passing anterior to it. What is this vein? It is called left brachiocephalic vein. So please keep, as this left common carotid is passed and crossed by this left brachiocephalic vein. And by the way, it is also crossed by cardiac branches of vagus nerve. And this is here will have anterior part of the lung, which is the pleura, and if you have also thymus gland. So 4 structures anterior to it in the thorax. Left brachiocephalic, cardiac branches of vagus, lung with its pleura, and you have the thymus gland. This is its course of the left common carotid artery in the thorax. But what about its course in the neck? This artery passes deep to the sternocleidomastoid until it reaches the anterior triangle within the carotid triangle. It passes within the carotid sheath. Now, please tell me, what is the relation of the carotid artery to the internal jugular and to the vagus? Please keep this. I will try to write. Common carotid artery is anteromedial to internal jugular vein. So common carotid artery is anteromedial to internal jugular vein, while vagus is posteromedial to internal jugular vein. This is the relations. I will try to draw as here. So this is anteromedial, common carotid. Then you have a nerve, which is posteromedial. I have internal jugular, which is lateral. This is arrangement of the structures within the carotid sheath. Please keep this. After it starts behind the sternoclavicular joint, as it arises from the arch of aorta or the brachiocephalic. When it ends here, opposite this. What is this? This is the thyroid cartilage. Opposite the upper border of the thyroid cartilage. I said before, I have 3 bones within the midline, or 3 cartilage within the midline. They are arranged into this word, HTC. HTC. What is this arrangement? This is the hyoid, thyroid, cricoid. Hyoid bone is found at level C3. Thyroid, I have upper border and lower border. Upper border thyroid cartilage is at C4. Lower border thyroid cartilage is at C5. While cricoid is at C6. So keep this 3, 4, 5, 6. This is HTC. hyoid, thyroid, cricoid. At the upper border of the thyroid cartilage, this is C4. And all of you in exam is answering dividing of the carotid opposite C6. This is wrong because you have multiple events occurs at C6. So C6 is common for you more than C4. Please keep this. This is the site of division of common carotid into internal and external carotid. Now, you have known the relief common carotid, vagus, and jugular vein into the carotid chase. But what is the relation of internal carotid and the external carotid within the carotid chase? Keep this. External carotid artery is superficial and medial to internal carotid artery. So external carotid artery is superficial and medial to internal carotid artery. So here is the end of the common carotid. It is opposite the upper border of the thyroid cartilage, C4. Then now, let's go for branches of each carotid artery. We will start by discussing the external carotid. I will try to share the previous picture for external carotid. It's very important. This one, as you see, this is the external carotid. External carotid artery started opposite the upper border of thyroid cartilage, C4. This is easy. Where it ends here. This is the end of the external carotid. This opposite the neck of the mandible. This is the head, and this is the neck of the mandible. So opposite the neck of the mandible, by dividing into two major arteries. What are these two arteries? This is maxillary artery, and this is superficial temporal artery. So here they are the two terminal branches of the external carotid, maxillary and superficial temporal artery. What are the branches of the external carotid artery? What are the branches from the external carotid artery? Here, external carotid, first, it is found, as we say, superficial and medial to the internal carotid, and it passes on both sides of the pharyngeal wall. As you see here, this is the pharyngeal wall, and they are the constrictors of the pharynx. So this artery passes lateral to the pharyngeal wall. Here, it passes under cover of two muscles. They are posterior pili, digastric, and the stylohyoid muscle. This artery is passed by hypoglossal nerve, lingual nerve, and facial veins to pass into the submandibular or digastric triangle. Then it ends after it pierces the parotid gland. This is the parotid gland here. So again, from below upward, it starts opposite the upper border of C4. Here you have the sternocleidomastoid. Here you have also posterior pili-digastric and stylohyoid. Then also, it passed by hypoglossal nerve, lingual nerve, and facial vessels. Then it enters the parotid gland as one of content of the parotid gland, because you have three important contents of the parotid gland: external carotid artery, retromandibular vein, and facial nerve. You have artery, vein, nerve. They are contents of the parotid gland. After it passes through the parotid gland, it ends by dividing opposite the neck of the mandible by superficial temporal and maxillary artery. Here, I will try to collect what are the branches of the external carotid artery. Some American ladies found our pyramids most satisfying. This is the branches of external carotid. Again, some American ladies, as we are Egyptians, found our pyramids, this is B, most satisfying. Some S, this is the superior thyroid artery. A, this is the ascending pharyngeal artery. L is lingual artery. F, facial artery. O, This is the occipital artery. B is a posterior auricular, and the last MS is the two terminal branches, maxillary and superficial temporal. Again, some American ladies found our pyramids most satisfying. This is superior thyroid, ascending pharyngeal, lingual, facial, occipital, posterior auricular, maxillary, and superficial temporal. All of this are coming in the exam by another way. It comes in the exam. Branch is passing from the anterior part of the external carotid. I have three from the anterior part. First one is superior thyroid. As it passes here, this is the superior thyroid. Second one is a lingual, which passes here. Third one is facial. So this is R3 from anterior, superior thyroid, lingual, and facial. While from behind, this is a posterior auricular and occipital. While from its deep part, I said it passes on the lateral wall of the pharynx, so it gives ascending pharyngeal artery. These are 6 branches, and the 2 terminal branches, they are superficial temporal and maxillary. There are 8 branches from the external carotid. Where it ends opposite the neck of the mandible by dividing into superficial temporal and maxillary. Let's read this, as you see in the next page. These are branches of the external carotid. From the front, you have superior thyroid, lingual, and facial. 2 from behind, these are occipital and posterior auricular. From its deep, as it passes on the lateral wall of the pharynx, it gives you ascending pharyngeal artery, and ends opposite the neck of the mandible by dividing into superficial temporal and maxillary. Then you have on the next page, I will share. As you see here, they are the branches of the external carotid. I have collected them here. First one is superior thyroid artery, which passes until it reaches the upper pole of each lobe of the thyroid gland by dividing into anterior and posterior thyroid branches. This artery, by the way, is not supplying the lobe of the thyroid gland only, but it gives you another branches. What are these branches? They are related to the hyoid. You have infrahyoid branch. You have sternomastoid branch. You have cricothyroid branch, and you have thyroid branch. So this superior thyroid artery is not giving only the lobe. It gives you infrahyoid, it gives you cricothyroid, it gives you sternomastoid branches. Then you have another artery, which is ascending pharyngeal artery. This is for supply of the pharynx. Also, it supplies tonsils and palate. The lingual artery. This artery, as it passes here, I will try to zoom on it. As you see, this is the lingual artery. This one, I will try to make it by blue. This one, as you see, this is the lingual artery, which is arising from here, from the front of the external carotid. It is divided into 4 branches, second, third, and fourth. And the muscle, which is related to it, this is the lateral pterygoid. You have, from its first part of the lingual, you have what's called suprahyoid artery. This is above the hyoid, as you see here. This is a suprahyoid artery. Then you have, from its second part, you have 2 dorsal lingual arteries. Then you have, from its third part, you have what's called sublingual artery. So you have, from its second part, dorsal lingual, from its third part, sublingual, from its end, you have deep lingual. By the way, you have dorsal, sublingual, deep lingual, from second, third, and fourth. They are branches from the lingual arteries. Then you have facial artery. And the facial artery, which is related to the submandibular gland in the digastric triangle. I said you have 3 nerves, you have facial artery and facial vein. A common question asked about facial artery. where you feel pulsation of this facial artery? The answer is just anterior to the border of the masseter muscle. Masseter muscle is a muscle of the mastication. You can feel pulsation of facial artery just anterior to the border of this masseter muscle. And keep this one. Then you have occipital artery. You have a question in recalls regarding occipital artery. A patient who is undergoing pinning of the skull vault. And after pinning removal, you have a bleeding from its port. Which vasculature is injured? It is occipital artery. So pinning of the skull vault and you have a structure which is injured, this is occipital artery. Then you have superficial temporal artery, which is part of the two terminal branches after it passes opposite the neck of the mandible. Maxillary artery is another scenario because maxillary artery has multiple parts and this is not needed. Let's go for internal carotid artery. As you see here, I will share this one. This is the internal carotid artery. Internal carotid artery, which started opposite the neck of the mandible. Then it has a very important course. After it passes in the neck of the mandible, it has no branches in the neck. Keep this, no branches in the neck. How it reaches the skull? It passes from below through what's called the carotid canal. This is from below. From the upper part of the skull base, it passes through what's called the foramen lacerum. We will know all foramina within the base of the skull. We have four important foramina. They are collected into this word, Russell. This is rotundum, oval, spinosum, and lacerum. Rotundum, oval, spinosum, and lacerum. Rotundum is for maxillary nerve. Oval is for mandibular nerve. Spinosum is for middle meningeal artery. Lacerum is for internal carotid artery. So here for two nerves, here for two arteries. This is rotundum, oval, spinosum, and lacerum. From foramen lacerum, this is the site for entry of this internal carotid artery. After it passes here, it goes within, apart from the dural venous sinuses. It is called cavernous sinus. It is apart from the dural venous sinus, which is found opposite both sides of the pituitary gland. Here I have the pituitary gland found within part of the skull. It is called sella turcica. And this is, by the way, opposite the body of the sphenoid bone. Then I have on both sides of the sella turcica, which is the site for the pituitary gland, you have cavernous sinuses. After it passes through the cavernous sinus, and we will discuss all structures passing through the cavernous sinus, it is dividing into anterior and posterior, anterior and middle cerebral arteries. Where is exactly? It is just lateral to optic chiasma, and keep this. So here again, from the start, it started opposite the upper border of the thyroid cartilage, opposite C4. It passes within the carotid sheath. External carotid artery is superficial and medial to the internal carotid artery. This internal carotid artery has no branches in the neck. How it reaches the skull? It passes from below into the carotid canal and from above into the foramen lacerum. Then it enters the cavernous sinus to end just lateral to the optic chiasma by anterior and middle cerebral. Only anterior and middle cerebral are branches from internal carotid? No. These are branches from the internal carotid. What is the first branch, and usually come in exams? What is the first branch to arise from internal carotid? It is called ophthalmic artery. So ophthalmic artery is the first branch to arise from the internal carotid. This is usually and commonly asked. So first branch is ophthalmic artery. After it, it gives you anterior, choroidal, and posterior communicating. And by the way, posterior communicating is sharing in the circle of Willis. Circle of Willis. When you have rupture of a Paris aneurysm found within the middle cerebral artery aneurysm sharing in the circle of Willis, this is causing subarachnoid hemorrhage. So here you have 5 important branches. First branch is ophthalmic artery. What is the surgical importance of this ophthalmic artery? This is, by the way, is an end artery. What means by end artery? Occlusion of this artery equal blindness. Equal blindness. So this is an end artery. This is the first branch to arise from the internal carotid. Then you have anterior choroidal, posterior communicating anterior and middle cerebral arteries. Then you have another hypophyseal arteries. They are superior and inferior hypophyseal arteries. Once it passes within the cavernous sinus, I said this is called hypophysis cerebri. Hypophysis cerebri, which is the pituitary gland. On both sides, this is the cavernous sinus. It gives you to this hypophysis cerebri superior and inferior hypophyseal arteries. Then it also gives meningeal arteries. All of this is not needed from this relation, but here keep this. Here keep this relation within the carotid canal. It passes within the carotid canal until it reaches from inside the skull through the foramen lacerum. What are the relations within the carotid canal? The most important one is this. It is called the trigeminal ganglion, and it came in exam before. Which structure is related to the internal carotid within the carotid canal? It is the trigeminal ganglion and came in records before. So better to keep it. Then you have internal jugular, which is another content from the carotid canal. Internal jugular, when and where it starts. It starts as a continuation of what's called sigmoid sinus. You have multiple dural venous sinuses. The most important one is called sigmoid sinus on both sides. Continuation of the sigmoid sinus on both sides, after it passes here, it gives you what's called internal jugular. And by the way, this sigmoid sinus passes through the jugular foramen from the base of the skull. So here, this sigmoid sinus passes through the jugular foramen, and the continuation of it is forming what's called the internal jugular vein. After it passes, it has superior jugular bulb, and it passes its length through the carotid canal, and it also has inferior jugular bulb before it joins the subclavian vein to form the bucocephalic or mnemonic veins. So how this vein is ended? Here, it ends by joining the subclavian vein to form the precucephalic vein, just behind the medial end of the clavicle, and in some questions behind the sternoclavicular joint. So here, this is the site for start of this internal jugular vein as a tributary which joins the subclavian vein to form the precucephalic or mnemonic vein behind the sternoclavicular joint. I said relation of common carotid and vagus to internal jugular. Internal jugular is the most lateral, while anteromedial is common carotid and posteromedial is the vagus. This is very important. Here, you will tell me what are the tributaries of internal jugular. What are the tributaries of this internal jugular? Tributaries, you will try to focus. First one is continuation from the sigmoid sinus. This sinus is first one. Second one is called inferior petrosal sinus. So I have two sinuses. Then I have two thyroid branches, superior and middle thyroid. Then I have two related to the face. This is lingual and common facial veins. Now it became easy. I have two sinuses. I have two veins related to the thyroid. I have two veins related to the face. What are these two sinuses? I have inferior petrosal sinus and sigmoid sinus. What are these veins related to the thyroid? I have superior and middle thyroid. What are veins related to the face? This is the lingual and common facial vein. Start, end of internal jugular and the tributaries are very important. Then let's go for next slide. We discussed internal jugular. Then let's go for scalene muscles. Here we have discussed all posterior triangle, and these are the contents of the posterior triangle. I said you have muscles, which is inferior belly of omohyoid and anterior scalene muscle. And the lymph node, you have supraclavicular and occipital. Supraclavicular and occipital. While nerves and vessels, I said external jugular and subclavian artery, while this subclavian artery is related to the trunks of the brachial plexus. But you have subclavian vein, which is related to the phrenic nerve. Nerve passing between the sternocleidomastoid and the trapezius and supplying both of them, it is the accessory nerve. While you have 4 branches of cervical plexus, supraclavicular, transverse cervical, great auricular, and lesser occipital. All of this are content of this posterior triangle. What are the boundaries? You have anterior is the sternocleidomastoid, posterior is trapezius, and your base is the middle 1/3 of the clavicle. While floor is LSS, SLS, splenius capitis, levator scapulae, and scalenus medius. Here you have 3 scalene muscles, scalenus anterior, medius, and posterior. We will share all anatomical landmarks of all of them, but just to know that scalenus anterior and medius are related to the first rib, while scalenus posterior is related to the second rib. Arrangement of the structure is very important. I will try to write it again. Related to the scalene muscle, subclavian vein, lower trunks of the brachial plexus. This is from anterior to posterior. Then you have, this is the subclavian vein. Then you have phrenic nerve. Then this is the scalenus anterior. Then you have structures between scalenus anterior and medius. What are these structures? They are the subclavian artery, lower trunks of the brachial plexus, then you have scalenus medius. So what's all anterior to this scalenus medius is the content of the posterior triangle. Subclavian vein, phrenic nerve, scalenus anterior, then you have subclavian artery and lower trunks of the brachial plexus. This is arrangement of the structure related to the scalene muscles. Let's go for next page. This one. As you see, this is the muscles. We discussed the sternocleidomastoid, which has a sternal head and a clavicular head. Sternal head from the body of the menobrium, then you have clavicular head from medial 1/3 of the clavicle to be inserted into the mastoid process and superior nuchal line. Its innervation is accessory, where it receives a proprioception from C2 and 3. Trapezius, discussed in upper limb. This is from the superior nuchal line, ligamentum nuchae. Then you have also all cervical spine, and you have the thoracic spine. And the insertion of this trapezius is impressed by origin of deltoid, lateral 1/3 clavicle acromion and spine of the scapula. Innervation is accessory nerve and the proprioception from C3 and 4. Its action is shrugging shoulder. Just keep this, shrugging shoulder. Then you have, leave this splenius capitis and levator scapulae and the posterior scalene. Just to know, anterior and middle scalene. Because anterior scalene is arising from C3 to C6. To be inserted into first rib. While the middle scalene is arising from all cervical. Or cervical, not from 2 to 7. It is from all cervical, from 1 to 7, to be inserted also into the first rib. So scalenus medius is easy. It arising from all cervical vertebrae. While the anterior scalene is from C3 to C5. You have omohyoid, and I said omohyoid has superior belly and inferior belly. Superior belly omohyoid, which is related to the hyoid bone. and its lower part. What's meant by omo? I said omo is a scapula. Omo is a scapula. So here it is related to the scapula. And its intermediate part is related to the clavicle by a fibrous hood. Superior pileo-omohyoid and inferior pileo-omohyoid. So superior pileo-omohyoid from the hyoid to the clavicle and inferior pileo from the clavicle to the scapula. This omohyoid muscle is part from the infrahyoid muscle, and it is part of the strap muscle supplied by ansa cervicalis. Infrahyoid are responsible for depression of the hyoid bone. Thoracic outlet is the tight scalene syndrome. Tight scalene syndrome. This is compression of the vasculature between anterior and middle scalene. There, brachial plexus plus subclavian artery. Brachial plexus plus subclavian artery. Very important nerve as a content from the posterior triangle. It is the phrenic nerve. Origin of the phrenic nerve from C3, 4, and 5. I will try to show you a picture showing this phrenic nerve. As you see here, this is a phrenic nerve on the right side and on the left side, which is arising from C3, 4, and 5. What's its supply? It supplies the diaphragm as a motor. While sensation, it gives you the central part of the diaphragm associated with the pericardium. So motor to all diaphragm, while sensory to the central part of the diaphragm and the pericardium. Now you will ask me, from where the peripheral part of the diaphragm takes sensation? It takes sensation from intercostal nerves. Intercostal nerves, and this question came last January 2021 exam. Here, this is innervation of the diaphragm. Motor, all from phrenic. While sensory, central part is from phrenic, and its peripheral part from intercostal nerves. Then let's go back to the phrenic nerve, which is arising from C3, 4, 5, and it passes within the relation to the internal jugular vein. Has a common relation to the internal jugular vein across the anterior scalene muscle, just anterior to the anterior scalene muscles. Then you have a common relation of the phrenic on the right side and on the left side. On the left side, it is related to the first part subclavian artery. While on the right side, it is related to the second part subclavian artery. So on the left, it is related to the first, while on the right, it is related to the second part subclavian artery. It passes anterior to the scalenus anterior muscle, then it reaches the thorax. It passes anterior to the hilum of the thorax, because you have anterior to the hilum is phrenic and posterior to the hilum is vagus. So anterior to the hilum of the thorax. Then you have passage to special hiatus for HN1 in the diaphragm. This right phrenic passes with the IVC opposite T8, while the left phrenic has a special hiatus into the diaphragm. So this is all you should know about phrenic nerve. Phrenic nerve again is coming as origin from C3, 4, and 5. Its innervation, motor to the diaphragm, sensory to the central part only of the diaphragm and pericardium, while the peripheral part of the diaphragm is by intercostal nerves. It passes related to the internal jugular vein, just anterior to the scalenus anterior. This left part is related to the first part subclavian, second part, this right side is related to the second part subclavian. Then it passes within the thorax, just anterior to the hilum of the lung. Right side passes through the diaphragm with the caval opening, vena caval opening, opposite T8, while its left part has a special hiatus, special opening of the diaphragm. Now, let's discuss the subclavian artery. This is the subclavian artery. And as you see here, where is the start of the subclavian artery? Now you will ask me, right or left? Right subclavian artery is a branch from the precucephalic artery, like the common carotid. While left subclavian artery is arising from arch of aorta. Okay. This subclavian artery has a very important relation in its course. It passes just posterior to the scalenus anterior, between scalenus anterior and the medius. And this is the most important landmark. So here, it is deep to scalenus anterior and the anterior to scalenus medius. What are the branches of the subclavian artery? I have collected them into this word, vitamin C and D. Vitamin C and D. This is VIT, C and D. So this is vertebral, internal mammary artery, thyrocervical trunk, costocervical trunk, and dorsal-scapular artery. These are branches of this subclavian artery. And this is the most important point here. What are the branches of the subclavian artery? These are vitamin C and D, vertebral, internal mammary, thyrocervical, costocervical, and dorsal-scapular. Alone, we will stop here? Not. This is a vertebral artery. What are the branches of vertebral artery? 3 important branches. And you should keep them. Anterior spinal, posterior spinal, and posterior inferior cerebellar artery. This is a pica. Posterior inferior cerebellar artery. What means by posterior inferior? So you will have anterior inferior cerebellar artery. Yes, I have anterior inferior cerebellar artery. And as you have inferior, so you have superior cerebellar artery. Yes, I have superior cerebellar artery. But these are not coming from the vertebral, they are coming from the basilar. So here, the other branches are coming from basilar. What are the branches of vertebral arteries? They are anterior and posterior spinal, then posterior inferior cerebellar artery. Second artery is internal mammary. A very important information only regarding internal mammary is it divides opposite the neck of the sixth rib to be divided into 2 important branches, musculophrenic and superior epigastric. Musculophrenic and superficial epigastric. Then you have superior epigastric, excuse me, not superficial. Then you have thyrocervical trunk. This thyrocervical trunk is giving you 3 important branches. What are the 3 important branches of this thyrocervical trunk? First branch is inferior thyroid artery. And if you remember, superior thyroid is a branch from external carotid, while inferior thyroid is a branch from here, from thyrocervical trunk, which is coming from this subclavian artery. First one is inferior thyroid artery. Second one is transverse cervical. Third one is suprascapular artery. These are the 3 branches from thyrocervical trunk: inferior thyroid, transverse cervical, and suprascapular artery. Then costocervical trunk. Costocervical trunk is giving you 2 important branches: superior intercostal and deep cervical artery. Superior intercostal and deep cervical artery. Then you have last one is dorsal-scapular artery. This is all you should know about subclavian artery in MRCS. Let's go for root of the neck. Root of the neck. You have here a syndrome called thoracic outlet syndrome, and I discussed it. While the subclavian vein, which is found anterior to the scalenus anterior muscle, and this is related to the first rib, while subclavian artery passes between anterior and medius. Here I have collected multiple of muscles to know its origin, insertion, nerve supply, and action. First one is the stylohyoid. From its name, it is from a styloid process to be inserted into the hyoid bone. And this stylohyoid is related to the posterior pili-digastric from the second branchial arch, which is innervated by fascial nerve. So stylohyoid is related to posterior pili-digastric, which is second branchial arch fascial nerve. This is the digastric, anterior pili and posterior pili. Anterior pili, which is originating from digastric fossa of the mandible. Posterior pili is arising from the mastoid process, while both of them are inserted into the tendon of the hyoid bone. Innervation, anterior pili into mandibular branch of the trigeminal, posterior pili into fascial nerve. Then you have mylohyoid muscle. This is the most important one. And the other muscles, they are infrahyoid muscle and supplied by ansa cervicalis, except this thyroid muscle. I said it takes origin from C1 and hypoglossal nerve. C1 and hypoglossal nerve. But what about mylohyoid muscle? You have a line within the inner aspect of the mandible called the mylohyoid line. So this is the mandible, as you see here. You have line here called the mylohyoid line on both sides. It gives the fiber as it passes backwards and medially. These are the muscles of mylohyoid on each side. So from mylohyoid line, as you see here, and it passes backward and medially. Anterior 3 and 4 are inserted into the medial raphe, while its posterior part is inserted into the body of the hyoid bone. Body of the hyoid bone. What is the innervation of this mylohyoid muscle? It is nerve to the mylohyoid, which is arising from mandibular branch trigeminal nerve. Mandibular branch trigeminal nerve. And all other muscles, origin and insertion are not needed, just to know the innervation. Then, this is the HTC, which is the surface anatomy in the neck. I discussed it before. Hyoid, thyroid, cricoid. Upper border of thyroid cartilage opposite C4. Lower border of thyroid cartilage opposite C5. While cricoid is opposite C6. Here, a very important collection for events which are occurring at the level of the C6. You have multiple events, and I have here just collected 7 events which are occurring opposite C6. First one is continuation between larynx into trachea and pharynx into esophagus. So larynx into trachea, pharynx into esophagus is opposite the level of C6. Then you have level of inferior thyroid artery. Inferior thyroid artery, I said before, it arising from thyrocervical trunk first part subclavian artery. You have a very important artery also, which is arising from subclavian. It is called vertebral artery. And the vertebral artery started to enter the foramen transversarium of C6. Not entering C7 because it has a narrow foramen transversarium. C7, I said before, it is called vertebrae prominence. And this is the first bone to have prominent spinal process. This is the first spinal process you can feel by your back from above. This is the first spinal process you can feel from above in your back at the lower border of the nape. This is called vertebrae prominence, and this is C7. It has a narrow foramen transversarium, so wide foramen transversarium is opposite C6. Then it enter into the foramina until it reach C1. So here, this is the vertebral artery. This is the fourth event. First 2 events is hyoid, this is the larynx into trachea, then pharynx into esophagus. Then you have inferior thyroid artery, then you have vertebral artery. You have a muscle and a ganglion. What is this muscle? It is superior biliomohyoid, which is crossing the carotid sheath. And this is a very important relation. I will try to make it simple for you. This is a carotid sheath, which is related into 3 anatomical landmarks, C6 and C4. C4 is the upper border of the thyroid cartilage, and this is the end of the common carotid into external carotid and the internal carotid. While C6, you have 2 important landmarks. First one is the superior biliomohyoid is passing in front of the carotid sheath. This is the first event. Second one, you can feel and compress this common carotid artery opposite the carotid tubercle of the cricoid bone. And here, if you have hemorrhage from this common carotid artery, you can control it by compressing of this common carotid artery opposite carotid tubercle of the transverse process of C6. These are all events occurring at C6. A very important landmark to know the difference and relation of common carotid to C6 and C4. And please don't miss this. Next page. This is regarding, after we discussed root of the neck, this is the larynx. Larynx. Larynx started from C3, this is the hyoid bone, until it reaches C6. Below C6, this larynx will continue as a trachea. So this is the first information regarding larynx. Larynx has very important bones. I will try to share a simple one for you regarding the larynx. I have collected before. As you see, this one. These are related of the larynx, and this is typically as the same come in EMRCS. You have three paired bones. First one is the thyroid, as you see here. This one, this is the thyroid cartilage, which is found on both sides. This is one. This is a single thyroid. Then you have second one is the cricoid. This one. Then you have third one is the epiglottis. So from above below, you have epiglottis, thyroid, and cricoid. These are the three single. You have single thyroid, you have single epiglottis, and you have single cricoid. Then you have beard. What are the beard? You have first one is arytenoid. As you see, arytenoid is here and here. This is the arytenoid. Then you have corniculate and cuneiform. Corniculate is the small hair, which are rounded here. As you see, I will try to zoom. As you see here, this is here, are called corniculate. Then you have cuneiform, which are slightly anterior. All of this are forming the larynx. They are the cartilaginous segment forming the larynx. I will try to show you another one for anatomy of the larynx. This one, which will make it simple. As you see here, you have what's called the vestibule. And this is an anatomical landmark which is dividing the larynx into above the vestibule and below the vestibule. So this is the vestibular fold. What is this vestibule? This vestibule is just a mucosal fold and area which is widened above the vocal fold. This vocal fold, which is formed by vocal ligament and vocalis muscle. Above this vocal ligament and vocalis muscle, you have what's called the vestibule. This vestibule is above this area of the vestibular fold. Above it, you have what's called supraglottic area or vestibule. Below it, you have the infraglottic area. So here, you should know the vestibule, you have vocal fold, you have supraglottic area, you have infraglottic area. Let's go back for a very important schedule for muscles acting on the larynx. I know larynx is slightly difficult, but we will try to make it simple. Here you have the vestibule, which is found superior to the laryngeal fold, here, as you see here. Then you have the ventricle. This ventricle is area which is found between the vestibular fold and superior to the vocal cord. I will try to show you where is the ventricle. This one. This one. As you see here, this is the area of the ventricle. This area of the ventricle, which is found between vocal cord and the vestibular fold above. This is called the ventricle. While the infraglottic cavity, this area, which is found below the vocal cord. These are spaces should be known in the larynx. Then let's go for muscles acting on the larynx. What are the muscles acting on the larynx? You have movements related to the vocal cord. First one, tense of the vocal cord. Second one is relaxation of the vocal cord. Then you will have adduction of the vocal cord and abduction of the vocal cord. So tense, relaxation, adduction, abduction. Each muscle is responsible for them, just to know innervation and action, not to know origin and insertion. So here, keep this schedule, but please do not keep origin and insertion. You should know innervation and action. First one, to cause tense of the vocal cord. We know it. It is called cricothyroid muscle. cricothyroid muscle, which is responsible for tensing of the vocal cord. And by the way, all laryngeal muscles are supplied by recurrent laryngeal nerve. In some books, it is called inferior laryngeal nerve, which is a branch from vagus, except except this muscle, except this cricothyroid muscle, which causes tension of this vocal cord. What is the innervation of this muscle? It is supplied from external branch of superior laryngeal nerve. When you tense this vocal cord, so you will have high pitched voice. So loss of high pitched voice, this is injury to the superior laryngeal nerve. This is paralysis of the cricothyroid muscle. Keep this. Then you have what will cause relaxation of this vocal cord, muscle called thyroarytenoid. Thyroarytenoid, between thyroid cartilage and the arytenoid cartilage. It will cause relaxation of the vocal cord. So how I will adduct this vocal cord? I will adduct by muscle called lateral cricoarytenoid. From lateral, it acts inside. Lateral cricoarytenoid causing abduction. While abduction, it is by posterior cricoarytenoid. Posterior cricoarytenoid, when it acts, it causing moving of this vocal cord outside. Again, tension by cricothyroid, relaxation by thyroarytenoid, while abduction by lateral cricoarytenoid and abduction by posterior cricoarytenoid. From where this laryngeal nerves come? This laryngeal arteries, excuse me, are coming from thyroid arteries. Superior thyroid from external carotid, inferior thyroid from thyrocervical trunk, first part subclavian artery. All of this are not important as the lymphatic drainage of the larynx. You should know that vocal cord is an area of watershed, of lymphatic watershed, how it has no specific lymphatic drainage. From above, it drains into superficial upper deep, from upper deep cervical lymph node, while the infraglottic area as the thyroid gland into the prelaryngeal and the pretracheal lymph node, then into lower deep cervical lymph nodes. Here, this is the lymph drainage of the larynx. The vocal cord itself has no lymphatic drainage, and it is called an area of lymphatic watershed. Supraglottic area into upper deep cervical, infraglottic into prelaryngeal and pretracheal, and this is into lower deep cervical. We will take rest for about 5 minutes and we will go back. let's go back. We will continue by muscles of mastication. Muscles of mastication. Very important to know that you have 4 muscles of mastication. I will try to share a very important photo regarding this, as you see, like this one. These are the 4 muscles of mastication. First one is masseter, which is arising from this zygomatic arch and the maxillary process of the zygomatic bone until it reaches into the lateral surface and ramus of the mandible. This is the first one. And here, the most important anatomical landmark is the facial artery can be felt anterior to the anterior border of the masseter muscle. Then you have temporalis, which is arising from the temporal fossa to be inserted downward into this coronoid process. Then you have another 2 muscles. They are lateral pterygoid and medial pterygoid. Medial pterygoid has superficial head and deep head. Superficial head is arising from the maxillary tuberosity and not appearing here, while its medial head is arising from the medial surface of lateral pterygoid plate. While lateral pterygoid has upper and lower, as you see here, upper and lower head. And keep this lateral pterygoid because this lateral pterygoid has a very important relation to maxillary artery. Upper head is arising from the roof of the infratemporal fossa. This is the greater wing of the sphenoid, while its lower head is arising from lateral border of lateral pterygoid plate. Its insertion, as you see here, in the capsule of the joint and also in the mandibular fossa. This is the lateral pterygoid. How to keep action and nerve supply of this muscles of mastication. Please, before I forget, this is the lateral pterygoid, upper and lower head. We have 2 structures passing between the upper and the lower head of lateral pterygoid. First one is buccal nerve. Second one is maxillary artery. And they are 2 important structures, buccal nerve and maxillary artery. Then how to keep action of muscles of mastication. All muscles of mastication causing elevation of the mandible, except lateral pterygoid by L causing lowering of the mandible by L. So all muscles of mastication elevate the mandible except lateral pterygoid lowering of the mandible. Another action, all causing protrusion of the mandible except temporalis by R, temporalis causing retraction of the mandible. So all can cause elevation except lateral pterygoid lowering, while all protrusion except temporalis by retraction. This is the action of muscles of mastication. Muscles of mastication all are arising from the first branchial arch. So all are supplied by mandibular branch trigeminal nerve. Then you have the thyroid gland. We will know anatomy of the thyroid gland after muscles of mastication. Here you have, this is the thyroid gland, as you see in this picture. Thyroid gland is formed by 2 loops, which are connected by isthmus, and this is maybe related to pyramidal lobe above it. Anatomy of this thyroid gland, here from the upper border of the thyroid cartilage, and here opposite the tracheal ring number 6. While the isthmus is related into tracheal rings 2, 3, and 4. 2, 3, and 4, this is the site for tracheostomy. So here, isthmus may be divided into tracheostomy. Another importance, what are the relations of this thyroid? You will have anteromedial. This is first by sternocleidomastoid passing here. Then you have strap muscles, sternohyoid, sternothyroid, thyrohyoid. Then what about its posterior relation? Posterolateral is the carotid sheath, as you see here, internal jugular and common carotid. While posteromedial, you have above pharynx and larynx, then below trachea and esophagus. In between them, recurrent laryngeal nerve. While all over its posterior aspect, you have the parathyroid glands. So what are the relations again of the thyroid gland? Anterior, you have sternocleidomastoid and infrahyoid muscle. Sternohyoid, sternothyroid, and thyrohyoid also with anterior jugular vein. Then posterolateral is carotid sheath, common carotid artery and internal jugular vein. Posteromedial, superior is pharynx and larynx. Below, you have trachea and esophagus, and in between them recurrent laryngeal nerve, and overall posterior is the parathyroid glands. Isthmus is related anterior to the strap muscles, while posterior to second, third, fourth tracheal rings. Here, we will go for arterial supply of the thyroid gland. I say superior thyroid artery is a branch from external carotid. Inferior thyroid artery, where it's like this, is a branch from thyrocervical trunk, first part subclavian artery. You have another artery, which is found in 10% of population. This is called thyroidaema artery. Thyroidaema artery is arising from this artery, this brachiocephalic artery, or may arise from the aorta. Brachiocephalic or the aorta. This is the thyroidaema artery. Venous drainage. We discussed internal jugular vein tributaries. I said two sinuses from above, inferior petrosal and sigmoid. Then two thyroid arteries, superior and middle thyroid. So superior and the middle thyroid are draining into internal jugular. While inferior thyroid veins, they are multiple veins. They are related to the left brachiocephalic vein. They are tributaries of the left brachiocephalic vein. Innervation, related to the upper pool, this is the superior laryngeal nerve. Related to the lower pool, this is inferior laryngeal nerve. Superior laryngeal nerve is divided into the upper pool into external and internal. This external branch will supply the cricothyroid muscle, which is responsible for tension of the vocal cord. Paralysis will cause loss of high-pitched voice. But what about internal branch of superior laryngeal nerve? This will supply sensory to the mucosa above the vocal cord. But what about sensation to mucosa below the vocal cord? This is from inferior laryngeal nerve or recurrent laryngeal nerve. Recurrent laryngeal nerve is supplying all muscles of the larynx except the cricothyroid muscle. Then now, let's go for recurrent laryngeal nerve. Its course, as you see here, it is a branch from the vagus. Branch from vagus. On the right side, it passes anterior to the subclavian artery. Then it hooks around the subclavian artery. While on the left side, it passes surrounding the arch of the aorta. Subclavian artery and the arch of the aorta are arising from the fourth branchial arch. If failure of recurrent on the right side to pass around the subclavian artery, this is called a non-recurrent laryngeal nerve. Non-recurrent laryngeal nerve is most common on the right side when it fails to hook around the subclavian artery. After it arises above, it passes in the groove between the trachea and the esophagus until it reaches below the part of the mucosa below the vocal cord. It will give all muscles of the larynx. It will give sensation to the mucosa below the vocal cords. This is all you should know about recurrent laryngeal nerve. What about injury? Injury to this recurrent laryngeal nerve. I will try to make it simple. How will you keep this? Recurrent laryngeal nerve, partial or complete? Partial P, it will be related to breathing, P with P. While C complete, it will be related to vocalization. This is the sound. So partial, if unilateral or bilateral. While complete, if unilateral or bilateral. So partial unilateral, which is related to breathing, so it will be dyspnea on exertion. While partial bilateral, this is a stridor. While about vocalization, this is complete unilateral, it will be hoarseness. While complete bilateral will be aphonia. P is related to breathing, unilateral dyspnea, bilateral stridor, while C is related to phone or vocalization, unilateral hoarseness, bilateral aphonia. This is all recurrent laryngeal nerve injury. Then let's continue about parathyroid gland anatomy. This is a common question. We have 4 parathyroid glands. Can this number be changed? Yes, they are from 3 to 5 parathyroid glands. So in some persons you may find 3, in some persons you may find 5. They are related to the posterior border of the thyroid gland, lies within the pretracheal fascia. I have 2 superior and 2 inferior. These 2 inferior are related to the thymus gland. The inferior and the thymus gland are arising from the 3rd pharyngeal pouch, while the superior are arising from the 4th pharyngeal pouch with the thyroid. So superior with thyroid are related to the 4th, while inferior with thymus, which is T, thymus are related to the 3rd, which is T. So inferior is related to the thymus, related to the 3rd pharyngeal pouch. So if you didn't find this inferior parathyroid posterior to the thyroid gland in its site, where you can find them? You can find them into the superior mediastinum related to the thymus glands. This is also a common question. Embryology of this parathyroid gland is extremely important. Superior parathyroid are related to thyroid and they are arising from 4th pharyngeal pouch, while the inferior parathyroid related to thymus are arising from the 3rd pharyngeal pouch. Inferior parathyroids, if not present in their space, so they may be found into the superior mediastinum related to the thymus. Blood supply of this parathyroid glands from superior and inferior thyroid arteries. Then let's go for pituitary gland. And I say pituitary gland in some books, it is called hypophysis cerebri. Hypophysis cerebri, which are found within the hypophyseal fossa, which is called sella turcica. In the middle cranial fossa, this is the body of the sphenoid bone. This is the body of the sphenoid bone. This area has a raised area of bone in front and a raised area of bone behind. In front, it is called tuberculum silli, while behind, it is called dorsum silli. From dorsum silli, you have dural fold above this pituitary gland. It is called diaphragma silli. Diaphragma silli. So this space is called sella turcica. In front, tuberculum silli. Posterior, dorsum silli. Above it, diaphragma silli. Its origin. You have anterior pituitary and posterior pituitary. The most common exam, this is the anterior pituitary, which is arising from depression of whole pharynx called Rathke's pouch. This is embryology asked before. This is the Rathke's pouch. Anterior pituitary is related to the hypothalamus by hypophyseal portal circulation, while posterior pituitary is related to hypophyseal pituitary stalk. This is the neurological. So this is circulation, portal circulation. This is neurological innervation. 6 hormones from anterior pituitary: growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, luteinizing hormone, and follicle stimulating hormone, and prolactin. Related to ECTH, this is called MSH, melanocyte stimulating hormone. Then you have from posterior pituitary 2 hormones: vasopressin, which is called antidiuretic hormone, and oxytocin. Vasopressin and oxytocin are hormones from posterior pituitary. Then let's go for the most important topic for our lecture today. This is disorders of the oculomotor system and innervation of the face. What are the disorders of the oculomotor system? You have extraocular muscles. What are the extraocular muscles? I have recti, and as you see recti, this is the eye. I have superior rectus, lateral rectus, medial rectus, inferior rectus. I have obliques, superior oblique, which to be inserted into the lower part, and inferior oblique to be inserted into the upper part. So this is superior oblique and this is the inferior oblique. So I have recti and obliques. I will add to them a single muscle called levator palpebrae superioris. This is within the upper eyelid, levator palpebrae superioris. What is the action for each one? All extraocular muscles are supplied by cranial nerve number 3, which is called oculomotor, except SO4 and LR6. SO4 is superior oblique by 4, which is trochlear. LR6 is lateral rectus by 6, which is the abducent. So keep this. All extraocular muscles are supplied by cranial nerve number 3, oculomotor, except SO4 and LR6. Superior oblique by trochlear, and you have lateral rectus by abducent. Action for all of them. Recti is simple. So superior oblique for moving eye upwards, while inferior oblique downwards. Medial rectus for medially, lateral rectus for laterally. Here we will go for superior oblique. Superior oblique, once it causes traction above here, so it will move the eye downward and outside. Downward and outside. So this is depression and abduction. While the inferior oblique, which is inserted above, once it causes traction downward, so it will cause elevation and abduction. So this is the action of the muscles. Again, recti, superior rectus for elevation, inferior rectus for depression, medial rectus for medial, which is adduction, while lateral rectus for abduction. Superior oblique for depression and abduction. Inferior oblique for elevation and abduction. So now obliques will cause abduction. This is the first. Obliques will cause abduction. While all recti will cause adduction, except lateral rectus will cause abduction. So here I have 3 muscles for adduction and 3 muscles for abduction. 3 muscles for adduction, they are all recti except the lateral rectus. So the lateral rectus will be added here. And what are the 2 important muscles for abduction? Superior oblique and inferior oblique. So this is the simple action. Here, if you have injuries, let's go for injuries. First one, injury to oculomotor nerve. I have oculomotor nerve here, which is injured. I will have paralysis to superior rectus, inferior rectus, medial rectus. But the lateral rectus is supplied by 6. And the superior oblique is supplied by 4. So they will act. Once this act and this act, I will move downward and outward. Okay? This is simple. So oculomotor injury, I will be moving outward, abducted, and downward depressed. This is the first one. Second one, you will have loss of innervation to levator palpebrae superioris. So you will have dropping of the eyelid. This is ptosis. You will have paralysis to the ciliary muscles, which is responsible for sphincter pupilli, which is meiosis. So you will have mydriasis. You will have dilated fixed pupil. So please tell me 3 criteria of oculomotor nerve injury. First one, movement of eye downward and outward. Second one, ptosis. Third one, mydriasis. They are the 3 criteria of oculomotor nerve injury. This is simple. But what about trochlear nerve injury, which is responsible for moving the eye for SO4? SO4 is superior oblique. Superior oblique, you have movement of the eye downward and lateral. Downward and lateral. If superior oblique is paralyzed, downward movement will be kept by inferior rectus, while lateral movement will be kept by lateral rectus by 6, inferior rectus by 3. So here you will have no action except what is called vertical diplopia. This is vertical diplopia. Once you are moving your eye from above downward, you will see slight diplopia, because this superior oblique helps in this action with inferior oblique downward. You will have what's called vertical diplopia. But what about the lateral rectus failure? If you have lateral rectus failure, so you will have dominant action of medial rectus, so you will have convergence of the eye. Here, origin, insertion not needed for all extraocular muscles. Innervation and action is the most important. Innervation and action is the most important. Then let's discuss the parasympathetic ganglion. I have a very important photo for parasympathetic ganglion. Where is it? I will try to share. I have collected them before into the group. I will try to make it from the group. This one, as you see, I will try to share. This are all parasympathetic ganglion. We have four important parasympathetic ganglion. This one, as you see, what are the nerves? First, carrying parasympathetic. They are collected into 1973. 1973, they are 10, 973. Okay, then 3 is oculomotor. Then we have 7 is facial nerve. We have 9 is glossopharyngeal, and 10 is vagus. First one is ciliary ganglion. This is oculomotor, which is supplying the ciliary muscle and sphincter pupillae. Ciliary muscle and sphincter pupillae. Once you have paralysis of the ciliary muscle and sphincter pupillae, then you will have mydriasis. I said oculomotor nerve injury, you will have ptosis, mydriasis, and the movement of the eye downward and outward. This is through ciliary ganglion. Facial nerve is giving you 2 branches. Chorda tympani is going to the submandibular ganglion, then through lingual nerve, it would go into submandibular and sublingual glands. While through greater superficial petrosal, it will go into lacrimal glands through what's called sphenopalatine ganglion. Then I have from the glossopharyngeal nerve, innervation to the parotid gland. This is collected into this word, loa, through lesser superficial petrosal, into otic ganglion, through auriculotemporal nerve to the parotid gland. This is the parasympathetic. 4 parasympathetic ganglion should be kept. Ciliary, submandibular, sphenopalatine, then otic. Ciliary is oculomotor. It will supply sphincter pupillae and ciliary muscle. Submandibular is through chorda tympani from facial into submandibular glands and sublingual glands. While otic is through glossopharyngeal nerve, lesser superficial petrosal, otic ganglion, auriculotemporal nerve to the parotid gland. While sphenopalatine is related to the lacrimal gland, and by the way, this question came last January 2021. Sphenopalatine ganglion, this is innervated from greater superficial petrosal nerve of facial and supplying the lacrimal glands. Keep this. Question or 2 questions will come from this page. Then let's go for, after movements of the eye, let's go for visual field defect. As you see here, this is the optic nerve. Optic nerve has 2 fibers. These fibers are called the nasal fiber to go towards the nose. This fiber are called the temporal fiber towards the temple. This nasal fiber will see the temporal view, while this temporal fiber will see the nasal view. So keep this. Each nerve is formed of temporal and nasal fibers. The nasal fibers are decussating at the optic chiasma. Nasal fibers are decussating at the optic chiasma. And this is the first question. Optic chiasma is decussation of the nasal fibers of the optic nerve. Then, after it passes here, after this optic chiasma, you have what's called optic tract. Optic tract. Can you tell me? Optic tract is formed by nasal fiber of contralateral side and temporal fibers of the ipsilateral side. And this question came before. This question came before. Optic tract is formed by nasal fiber of the contralateral side and temporal fibers of this ipsilateral side. This is optic tract. After this optic tract, you have optic radiation and the occipital cortex, which is forming the visual cortex. Here, I have multiple lesions, and you will see this. If you have injury here, then you will not see either nasal or temporal. You will have complete blindness of this eye. Ipsilateral. This is simple. So here you will have this eye will be dark, and this you will see. Then let's go for here. As you see, this is the optic chiasma. This is the decussation of both nasal fibers. So I will have loss of the temporal field on both sides. This is called bitemporal hemianopia. Bitemporal hemianopia. So injury to the optic chiasma is called bitemporal hemianopia. In some books, this is a bipolar hemianopia. Bitemporal or bipolar hemianopia. Then, if you have injury here, this is number 4, optic tract. Once you have injury to the optic tract, so you will have loss of the temporal field on the contralateral side. And you will have loss to the nasal field on the same or ipsilateral side. What is this called? Lesion to the left optic tract is called right homonymous hemianopia bilateral. This is easy now. I will repeat again. Here you will have cut to the red, and here you will have cut to the yellow. To the red and yellow, this is R. Here is the nasal fiber which will see the temporal field, and this is the temporal fiber which will see the nasal field. Lesion of this and this is called right homonymous hemianopia. Right homonymous hemianopia equals left optic tract injury. This is the reverse, left optic tract injury. When you go back towards 3, okay, doctor. 3, this is injury to the temporal fiber of the left side. So you will have ipsilateral loss of the nasal part here. This is called left nasal hemianopia. This is the left eye, and this is the nasal side, and this is hemianopia. Injury here will cause what's called left nasal hemianopia. And this is not coming. What come in exam? Not 1 and 3. Just you will keep 2 and 4. 2, bitemporal hemianopia. 4, homonymous hemianopia. If right homonymous hemianopia, this is left optic tract. If left homonymous hemianopia, this is the right optic tract. I will add a single note here and finish this visual field lesions. The note, it will be, once you go back to the optic tract until you reach optic radiation or cortex, you will have what's called a macular sparing. Macula is bilaterally represented in both cortex. Once you have injury here, so this side will compensate. So you will have a complete homonymous hemianopia. you will have a defect here, which is called a macular sparing. Again, what's meant by macular sparing? A macula is area found deep within the eye. This is a bilaterally represented within the cortex. Once you have injuries, then you will have a sparing on this macula. So injury to optic radiation or cortex, you will have what's called a macular sparing. I will tell you about some principles about the optic nerve. Two important principles. First one, it is not a true nerve, optic nerve. We say usually this is called an optic neurolimmal tract. Why? Because it has no pure neurolimmal sheath. This nerve is covered by meninges. So once you have increased the intracranial pressure, you will have compression of this optic nerve. Initially, your patient will present by what's called amaurosis fugax, then sudden blindness. So intracranial pressure can be presented into your eye. This is no neurolimmal sheath, and this is usually covered by meninges. Here, what's meant by congruous and incongruous? We know macular sparing. This is in the cortex and this is in the radiation. What's meant by congruous and incongruous? I have two important information. I will tell you to make it easy. We have what's called lateral geniculate body and the medial geniculate body. No further information needed. Lateral geniculate body is related to eye. Medial geniculate body is related to ear. Now, this is easy. So lateral geniculate body is related to eye. Lesions, which are formed before this lateral geniculate body are incongruous lesions. After this lateral geniculate body, they are congruous lesions. What's meant by congruous and incongruous? Congruous is identical lesion between the two eyes, while incongruous is not identical lesion between two eyes. So here, if you have incongruous lesion, so you will have injury before this lateral geniculate body. Here you will have lesion into optic tract. But what about congruous lesion? This is a lesion after the lateral geniculate body. It will be in the optic radiation and the cortex. Now, all of this became clear. The last issue about this visual field defect, the last issue is that once you have cortex, you will have parietal above and the temporal below. This parietal is saying the inferior part, while this temporal is saying the superior part. This is collected into this word, pits. So parietal is related to inferior, temporal is related to superior. How will this come? If you have lesion into the temporal, into the parietal, then you will have inferior anopium. If you have lesion in the temporal, then you will have superior anopium. This is the tip which come in exam. Let's read this visual field defect, and I hope that it became clear. As you see here, this is lesion number 1. You will have total eye blindness on the same side. Decussation of this nasal fiber, you will have loss of the temporal field bilateral. This is called bitemporal hemianopia or bipolar hemianopia. Injury to this left temporal fibers of the left eye, you will have what's called left nasal hemianopia. If you have injury to the optic tract here, you will have incongruous defect. But in the optic radiation and the cortex, you will have congruous defect, but with macular sparing. Congruous defect with macular sparing. You will have here, above is parietal, below is temporal. So above is parietal. Parietal is superior, while temporal is inferior. So lesion to parietal, which you see below, then you will have inferior is related to parietal, while in temporal is saying above. So lesion superior will be temporal. Now it became clear. Then let's go for next page regarding trigeminal nerve story. Trigeminal nerve story. We will discuss trigeminal and facial today. Trigeminal, which is the first one, I will try to make it simple. I will share first. This is the trigeminal, which I have written before. This is trigeminal nerve, which is cranial nerve number 5. Cranial nerve number 5. This is arising from motor and sensory. Motor and sensory. Motor is from nucleus of tractus solitarius, while sensory is from mesencephalic nucleus. This is the trigeminal ganglion, which is found within the roof of the carotid canal. Then you have 3 important branches: ophthalmic, maxillary, and mandibular. This is sensory, this is sensory, this is sensory, and the motor. So ophthalmic is sensory, maxillary is sensory, while the mandibular is sensory and the motor. This ophthalmic is divided into frontal, lacrimal, and nasociliary. Frontal is giving you supraorbital, supratrochlear. Lacrimal is end as a palpebral, while nasociliary giving you anterior and posterior osmoidal branches. Just to keep, ophthalmic is sensory, while maxillary is sensory also. But if you remember, the maxillary is giving you a ganglionic branch into sphenopalatine ganglion. Then also it gives you this area of a cheek, below the eye and above your teeth. Below your eye and above your teeth. So below your eyes, this is an infraorbital. Infraorbital will give you nasal, palpebral, and labial. While it gives you also zygomatico-orbital and zygomatico-temporal. Then you have superior alveolar, above your alveolar margin of the teeth. So from the eye to the teeth, this is infraorbital, zygomatico-facial, and zygomatico-temporal, then superior alveolar. But what about the most important one? This is the mandibular nerve. And this is which come in exams. Because mandibular nerve is a trunk and anterior division, posterior division. Trunk is giving you nerve to medial pterygoid. Nerve to medial pterygoid. Medial pterygoid is one of muscles of mastication. Also, it will supply tensor tympani and the tensor palati. So tensor tympani, tensor palati, medial pterygoid are branches from the trunk of mandibular nerve. While anterior gives you 3 motor and 1 sensory, while posterior gives you 3 sensory and 1 motor. Anterior gives you 3 motor, the rest of muscles of mastication, because I said all muscles of mastication are arising from first branchial arch and all are supplied from mandibular nerve. Here we know all muscles are supplied by anterior branch of mandibular nerve, while except the medial pterygoid from the trunk. Anterior, it will give you the remaining parts of muscles of mastication: masseter, lateral pterygoid, and the temporalis. And the sensory one is buccal. While the posterior, there are 3 sensory. What are the 3 sensory? Auriculotemporal, opposite the upper half of the auricle and the opposite area of the temple. The lingual nerve, which is giving you general sensation to anterior 2/3 of the tongue. And the inferior alveolar, which ends by mental and the incisive branches. But what about the motor? It is nerve to the myelohyoid. This myelohyoid will supply also anterior pili-digastric. I said anterior pili-digastric is from first branchial arch, supplied by nerve to myelohyoid, which is a branch from posterior division mandibular nerve. And also it will supply the anterior pili-digastric. This is all trigeminal nerve story. Please keep it. Very important. Let's go back to our page. This is the trigeminal nerve. We know sensory, which is from ophthalmic, pure, and maxillary pure, and some branches from anterior and the posterior division. While motor is only from the mandibular branch. Motor is only from mandibular branch. All muscles of mastication from anterior division except medial pterygoid from the trunk. Then also associated from the trunk tensor palati, tensor tympani. Then nerve to mylohyoid from posterior pili, it also will supply anterior pili-digastric. Then you will have multiple ganglion. From the maxillary branch, you will have sphenopalatine ganglion. Then you will have also from lingual branch, you will have through lingual branch into submandibular ganglion. Then you will have from auriculotemporal, from otic ganglion, I said, lesser superficial petrosal, otic ganglion, auriculotemporal into the parotid gland. Here, I will divide all cranial nerves as a presentation in the brainstem. This is the midbrain, this is pons, and this is medulla. Midbrain gives you 3 and 4 cranial nerves, while pons gives you 5, 6, 7, 8. And the last 4 cranial nerves are represented into the medulla. They are 9, 10, 11, and 12. So here, this is trigeminal nerve, which is originating from the pons. This is originating from the pons. It has sensory and motor. And I said, sensory is the nucleus of tractus serratus, which is found within the trigeminal ganglion, within the Meckel's cava. Within the Meckel's cava. And it is divided into 3 branches. Ophthalmic, maxillary are sensory, while mandibular is motor. Passage of HN1 through foramina into the skull is very important. Ophthalmic through superior orbital fissure. Maxillary through foramen rotundum, while mandibular through foramen ovale. Keep this, each one is asked in the exam. Motor we discussed and other muscles are discussed. Lingual nerve, which is a branch from posterior trunk mandibular nerve. Lingual nerve is supplying general sensation to anterior 2/3 of the tongue. And the lingual nerve is carrying parasympathetic until it reaches the submandibular glands. Then let's discuss next nerve, which is facial nerve. This is cranial nerve number 7. Cranial nerve number 7. This is the facial nerve. And here, facial nerve has a parasympathetic. Why? Because I said parasympathetic, they are 1, 7, 1, 9, 7, 3. So 3, 7, 9, and 10. This is 7. This is the facial nerve. So it carries parasympathetic. Parasympathetic is from superior salivatory nucleus. This is cranial nerve number 7. While glossopharyngeal nerve is carrying from inferior salivatory nucleus. Facial nerve has a sensory from nucleus of tractus solitarius like trigeminal, and the motor from the mesencephalic nucleus like also trigeminal. Facial nerve story, you have intracranial part and extracranial part. Facial nerve is arising from pons. Intracranial part giving you 3 branches. First one, greater superficial petrosal. This will go into pterygopalatine ganglion. This is related to lacrimal glands. While chorda tympani, I said chorda tympani will giving you tympani by T, giving you taste sensation to anterior 2/3 of the tongue. And this is one of the parasympathetic ganglion to the submandibular ganglion. Then you have nerve to stapedius, which is supplying a muscle called stapedius related to the middle ear. Intracranial part are 3 branches: greater superficial petrosal, chorda tympani, and the nerve to stapedius. While extracranial part, first one, it will supply posterior pili-digastric and stylohyoid. And I say both are passing this external carotid artery relation. And both are originating from the second branchial arch. So they are supplied by facial nerve, posterior pili-digastric and stylohyoid. Then you have posterior auricular, which is supplying the occipital fibers of fronto-occipital muscle. You have muscle found within the scalp, frontalis and occipitalis. Occipitalis is supplied by posterior auricular branch of facial nerve. Then it passes within the parotid gland to end as a 5 terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Marginal mandibular and cervical. This is the facial nerve story, and this is as simplified in our notes. Facial nerve, which is passing from supplying the second embryonic branchial arch. Here it's supply as it is written in EMRCS. Face, air, taste, and tear. Face, air, taste, and tear. Face, all muscles of facial expression, not muscles of mastication. Keep this. Muscles of mastication by mandibular branch of trigeminal nerve, while muscles of facial expression by facial nerve. Air, nerve to stapedius, through intracranial part, while taste through lingual. This, excuse me, there is chorda tympani. Also, this is the intracranial part. While tear, this is through also chorda tympani into lacrimal glands. Then you have its pathway. I said it's originating from the pons. Then it passes through the internal auditory meatus. Internal auditory meatus is passage through the petrous part of the temporal bone. You have here entry of this nerve. Internal auditory meatus is passage for 7 and 8 cranial nerves, facial and vestibulocochlear. All are passing through internal auditory meatus. 3 branches, intracranial, they are greater superficial petrosal, nerve to stapedius, chorda tympani. Then 3 branches extracranial, posterior auricular, posterior pilodigastric, stylohyoid, then within the parotid, temporal, zygomatic, buccal, marginal, mandibular, and cervical. Then, last one for today. This is representation of the face into the cortex. How to differentiate between upper motor neuron lesion and lower motor neuron lesion. Upper motor neuron lesion, this is within the cortex. Once you have the cranial nuclei and below, this is a lower motor neuron lesion. So upper motor neuron lesion is this tract, which is called corticopulbar tract. Where from the cranial nuclei and the nerves below, this is called the lower motor neuron lesion. Another one, upper motor neuron lesion will be contralateral, while lower motor neuron lesion will be ipsilateral. These are the 2 principles. Upper motor neuron is a corticopulbar tract, supranuclear level, while from nuclei below, this is lower motor neuron. This is the first principle. Second principle, upper motor neuron will be contralateral presented, while lower motor neuron will be ipsilateral presented. This is the second one. Third one is your upper part of face. Upper part of face is supplied by branch of facial nerve called the temporal, which is located within the posterior part of the cortex. This is bilaterally represented within the cortex. So upper part of face is bilaterally supplied from both cortices on both sides. This is from the left and right, and also on the right side, this is from left and right. While the lower part of the face is supplied by contralateral cortex. This is the lower part by contralateral cortex. And here, this is from this side. So once you have upper motor neuron lesion, once I have an upper motor neuron lesion, like I have lesion here, I have lesion here. This will be paralyzed? No, because it has innervation from here. This will be paralyzed? No, because it is innervated from here. But what about this side will be paralyzed? And this side, no, because it is supplied from here. So please focus. Once I have lesion here, the only thing which will be paralyzed is this. Not this, because it is supplied from here also. So once I have left upper motor neuron lesion, I will have paralysis of the right lower face. How to differentiate between upper and lower motor neuron? Do action of the upper face. What is the action of the upper face? Raising the eyebrow. Raising the eyebrow. Hope I think I have made it easy. I will show you photo of upper and lower motor neuron lesions. This is the side of the face. This is a lesion, supranuclear lesion. What means by supranuclear lesion? This is an upper motor neuron lesion. Here, there is no paralysis of this side because it's supplied from the opposite side. But here it will be paralyzed. Why? Because it's supplied here. So focus in this page. Once you have a lesion here, so you will have contralateral lower face is paralyzed. While when I have nuclear or below lesion, I will have ipsilateral half of the face is paralyzed. How to differentiate between lower motor and upper motor? You will raise the eyebrow in upper motor, not in lower motor. This is all you should know about facial nerve. Accessory nerve, which is cranial nerve number 11. This is arising from medulla. You should know, arising from medulla, and passes through the jugular foramen to supply two muscles, sternocleidomastoid and trapezius muscle. And it is one of the content of the posterior triangle. I have finished our lecture for today. I know this is a huge bulk for you. I think all of you have headache now.